One. Please start, sir. We are live.
Good evening, all distinguished delegates and today's eminent speaker, Dr. Praneeth sir. Without wasting much of our time, I would like to welcome all the delegates for this Clear Talk. Clear Talk, giving a small brief about Clear Talk. Clear Talk is one more facet of Unite Against Dyslipidemia. And the recent development in the field of management, dyslipidemia management, is bempedoic acid. The importance of this session is to give you the late breaking clear outcomes trial, which was presented in recently conducted American College of Cardiology. And to deliver bempedoic acid through the lenses of clear outcomes trial, we have one of the best faculty from King's Hospital, Sir Dr. Praneeth sir. Sir is senior consultant interventional cardiologist, King's Hospital, Secunderabad, having more than decades of experience in the field of cardiology, including clinical cardiology, interventional cardiology, complex coronary interventions, valvular heart diseases, structural heart intervention, and so many things, TAVR, TMVR, heart failure management, and preventive medicine. Sir has many honors. The few which I have noted here is Vaidyashree and Vaidyaratna. He was awarded with. Sir has many publications to his credit. I have jotted down few of the publications like Prolapse of All Cardiac Walls in Noonan Syndrome. And Sir, especially Sir's interest has also been in familial hypercholesterolemia. So accelerated atherosclerosis in and female with familial hypercholesterolemia. And we are fortunate to have Dr. Praneeth here to deliver bempedoic acid through the lenses of clear outcomes trial. Without wasting much of time, would like to hear from horse's mouth. I am handing over session to Dr. Praneeth. Thank you.
Yeah, thank you for the nice introduction. So as mentioned, so today's point of discussion is about learning this molecule bempedoic acid. So, and the focus of discussion will be on the recent clear outcomes trial. So I will try to understand, make you understand, and try to equally share my viewpoint on this molecule and how do I look into it. So the focus of discussion today is on the clear outcomes trial, particularly focusing on the molecule which is bempedoic acid. The question is, why do we need lipid lowering therapy, and where does the question of lipid lowering therapy start from? So if we go back in time and if you look at the role of cholesterol or role of lipids in atherosclerotic cardiovascular diseases, we all know that LDL cholesterol has a direct association with the atherosclerotic cardiovascular events. The higher the LDL cholesterol level, there is a direct proportion of increased incidence of atherosclerotic cardiovascular events. So that is where this concept of lowering the LDL cholesterol levels have come up, and over the last decade, we understand that the lower it is better, starting from the TNT trial. And there are many trials which have focused on the same thing. And a 1 millimole per liter, which close to translates as a close to 40 milligram drop in LDL cholesterol levels, there is a 23% relative risk reduction in the ASCVD events. And all the molecules are focused on the same thing. Statins, we know, are the cornerstone in lowering LDL cholesterol levels, but we have came to understanding that statins alone are not sufficient, either because statins are not being taken, or equally even after taking statins, there is still a large unmet need, which is there. There was a quest of trying for newer molecules, and that is where we are today. So as I was already focusing on, each 1 millimole reduction in LDL cholesterol levels gives a significant reduction in the cardiovascular events according to the trials number needed to treat. So here in trial and the risk reduction as we are going through, there is a direct correlation. The lower you drop the LDL cholesterol, there is definitely a reduction of ASCVD events. So the question or the concerns that we have is management of dyslipidemia is high on priority, and statins are first-line therapy. The two concerns, as I was mentioning, is do all statin users achieve LDL cholesterol goals as per the guideline recommendations? And how do you achieve the LDL target after maximally tolerated doses of statin, the so-called unmet need? So the first question, do all statin users achieve LDL cholesterol goals as per the guideline recommendations? Now, what are the guidelines and what is the goals that we have to achieve? So the LDL cholesterol target is based on risk stratifying a given patient. Now, how do we risk stratify the patients? There are ASCVD risk factors, and they are the clinical presentations that we need to look into. And patients are subsequently stratified into either low risk to high to very high risk and extreme risk. And Lipid Association of India also emphasized this risk stratification methods. So low risk are those subset of patients who have either 0 to 1 major ASCVD risk factors, and their lifetime risk is less than 30%. Moderate, they have 2 risk factors and their risk is close to 30%. High risk, the risk is further high. And extreme risk are again subdivided into category A and category B, depending on their risk profiles. And top, you have these major risk factors, high risk features, and moderate high risk features. The larger the number of risk factors, the higher is the risk. And when higher is the risk of the patient, lower should be the targets of LDL cholesterol levels. So based on the risk stratification, the Lipid Association of India has revised the LDL target for Indian population. So low risk people, their LDL cholesterol treatment goal should be less than 100, and non-HDL cholesterol goals should be less than 130. I'll try to stop my video so that the connectivity is better. Yeah. And for those who have extreme high risk, their optional goal is scarily less than 30. Most of them do get scared when their LDL cholesterol levels are less than 50. But this is what it is supposed to be. And the European or the American guidelines, they recommend LDL cholesterol levels of less than 55 for those patients who have high risk. So the European Society of Cardiology 2016 to 2019, they have also modified, where from earlier the targets were 115 and for high risk it was less than 70, but currently the targets have been modified. So those who have very high risk, their LDL cholesterol targets are less than 55, that is those who already have an event or those who are considered to be having significant risk factors. For primary prevention, the LDL cholesterol goal is less than 70. And for secondary prevention, the LDL cholesterol goal is less than 55. So based on these revised European Society of Cardiology 2019 guidelines, how many do reach the so-called LDL cholesterol goals, which are the so-called aggressive LDL cholesterol reduction? So European Union conducted a cross-sectional observation study, which was the Da Vinci study, which included close to 6,000 patients. And about 3,000 were primary prevention, about 3,000 in secondary prevention, which means they already had one ASCVD event. And if we look at those patients using the lipid-lowering therapy, predominantly statins, what was the amount of patients who are reaching those goals? So if you look at the overall study population, the proportion of patients who are receiving lipid-lowering therapy, if you look at, this is the proportion of those patients. So if you look at the 2019 guidelines, and if you look at this data, only close to 30% of patients are receiving high intensity statin, and about 30% of patients were only achieving the so-called lipid goals. So we know statins are classified based on their intensity to low intensity, to moderate intensity, to high intensity. High intensity, where you expect 30 to 50% reduction in the LDL cholesterol levels, and low intensity, you expect less than 30%. And high intensity statin by definition includes atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. So these are the only two molecules at that given strength, which is considered to be having a high intensity statin, and 30% are need to take high intensity statin, and 70% are not receiving. So there is a large unmet need, or under treatment is what we should say. So statin usage in the so-called very high risk patients who have significant risk of having ASCVD event. If you look at those proportion of patients, close to 40% of patients are receiving high intensity statins, and 22% only were able to achieve their lipid goal. So close to 80% of patients who are the so-called very high risk patients are not reaching their LDL cholesterol goals as per the ESC 2019 guidelines. So there is a large undertreated population, and so is their risk of having an ASCVD event. The second concern, how do we achieve the so-called LDL cholesterol targets after maximally tolerated doses? So you can't step up the dose of statin higher than what is already there. You can't give more than 40 milligrams of rosuvastatin, and you can't give more than 80 milligrams of atorvastatin. So how to reach or how effective are these lipid lowering therapy when you have reached the maximum doses? So if you look at this chart, ASCVD patients, you check their baseline levels, and those patients who already had an ASCVD event. And if you look at the subset, so close to 60 to 70% of patients, despite taking high intensity statin, their reduction in LDL cholesterol level was 50%. And for we all know that these percent of patients, their residual risk is still high, and we need to further reduce their LDL cholesterol levels. How can we achieve that? It is not possible by high intensity statin alone, and you need an additional molecule. That is where the whole discussion comes up. So high intensity statin has low adherence, which leads to decreased LDL cholesterol levels or not reaching the target goal, which ultimately leads to high major adverse cardiovascular events. So this is an observation study of close to 23,000 patients who had an acute coronary syndrome, and post that acute coronary syndrome, they were continued high intensity statin, of which only 66% were not taking high intensity statin after discharge. Only 40% were receiving high intensity statin, and 50% of patients had either drug interruption or end of therapy within first month, and because of which patients are not able to continue statins, and they have these major adverse cardiovascular events. Now, because there is a significant unmet need, patients do need significant lipid lowering therapy, and high intensity statins alone are not able to reduce the LDL cholesterol level. So this unmet need is the quest for finding newer molecules, which is where the PCSK9 inhibitors have come up, which are injectables. We all know patients do not like injectables. We need an oral alternative, which is where this newer molecule, which is bempedoic acid, comes into picture. It is an ATP citrate lyase inhibitor, a first-in-class lipid-lowering therapy, particularly focusing on LDL cholesterol levels. So there are approved indications of this molecule for reducing uncontrolled LDL cholesterol levels in patients who are receiving maximally tolerated statin dose. In those patients who have mixed dyslipidemia, who have familial hypercholesterolemia, or those subsets who have high-risk ASCVD events. It is also indicated in those patients in whom statins are not tolerated or in whom statins are contraindicated. Dosage is 180 milligram once daily, and it has no significant interaction with food, so you can take it either with or without food. So if you look at the story of bempedoic acid, it is approved by US FDA in February 20. It was approved by EMA in March 20, and it is recommended by Lipid Association India in August 22, and almost every society now approves it. And in March 23, we had this clear outcomes study, which we had the CVOT trial, and it is currently recommended by ILEP in April 23. So it has a molecule. So if you look at the mechanism of action, we need to go back to our biochemistry class and talk about how statins work and what is the lipid pathway. So if you look at this pathway, I won't take much of the time, but we need to understand that this molecule or this enzyme, the HMG-CoA reductase, is the regulatory enzyme or the key enzyme which converts this ACL, converts citrate into cholesterol synthesis, and statins focus particularly at this molecule, the rate limiting step in cholesterol synthesis. One step before HMG-CoA reductase is this ACL convertase, which is where the bempedoic acid is acting. So it is one step before HMG-CoA reductase. And because this happens exclusively in liver, bempedoic acid only acts on liver and it has zero effect on skeletal muscles. So all the so-called skeletal muscle associated or statin associated muscle symptoms are exclusively to statin, because statins act both on liver and at muscle. But because bempedoic acid is exclusive to liver, muscle symptoms are zero. So bempedoic acid is not activated in skeletal muscle, and this ACSLV is not expressed in muscles. So people who are taking bempedoic acid have zero muscle symptoms. So how do we manage patients who receive bempedoic acid if we have to give bempedoic acid? We need to understand that it has a long half-life of close to 20 hours. It is predominantly excreted through kidney and close to 5% is excreted through feces. For patients who have renal impairment, there is no significant dose adjustment. For those who have hepatic impairment, unless they are having end stage renal disease or end stage liver disease, you can safely give this molecule. There is a concern that serum uric acid levels is elevated. So those patients who have prior history of gout, you need to be cautious and you need to focus on measuring their uric acid levels. Patients who have more than 60 years of age who are also taking steroids or other quinolones or other drugs, there is found to be having an increased incidence of tendon rupture. So that also needs to be paid attention to. So increased levels of serum uric acid levels and possibly an increased incidence of tendon rupture, particularly those who are taking immunosuppressants, you should be cautious. So those patients who already have a history of tendon rupture, those who are already taking simvastatin and pravastatin, those who are pregnant and lactating women, for them it's an absolute contraindication, so do not give. So relatively safe molecule with very few patients whom you think you cannot give, but for most of the patients you can safely administer this molecule. Now let us come to the important trial, which is the late breaking trial, which was discussed in the recently conducted ACC conference, which is the CLEAR outcomes trial, where cholesterol lowering via bempedoic acid in ACL inhibiting regimen. So those patients who are not taking statins or who are intolerant to statin, we can't do anything. We have only statins. We have no other molecules which can reduce LDL cholesterol levels other than PCSK9. So in those patients, if you give bempedoic acid, how do they fare? So it's a global CVOT study which tried to look at those patients who are statin intolerant. If they are receiving bempedoic acid, how does their LDL cholesterol levels fare? So primary and secondary prevention patients were included in this study, and they were compared to placebo. So close to 14,000 patients with a median follow-up of 40 months. So what we tried to study, patients who are having statin intolerance, because you can't give anything else, give bempedoic acid and see for their cardiovascular outcomes. So there were primary and secondary endpoints. So the primary endpoints are the major adverse cardiovascular events, which includes non-fatal myocardial infarction, non-fatal stroke, the need for coronary revascularization, and the need for the incidence of cardiovascular death as a component, the primary component, which includes all four of them. And the secondary endpoint being three-component MACE, fatal and non-fatal MI, coronary revascularization alone, fatal and non-fatal stroke alone, cardiovascular death, and all-cause mortality. So if you look at this CLEAR outcomes, this is the demographic data, which is reasonably matched between both the arms, bempedoic acid and placebo arms. You see that the mean LDL cholesterol levels is 140, which is definitely high. So you expect them to have significant ASCVD events. Their eGFR was reasonably okay. Majority of the patients were having eGFR between 60 to 90, which is what we normally see. 30% of patients were in primary prevention group. 70% of patients were in secondary prevention. Among them, coronary artery disease seems to be the predominant subset. And most of the patients, close to 40% of the patients were diabetes, and about 20% were not well controlled. And statin use, only 20% were able to receive statin. Estimab was tried, and close to 11% of patients were receiving statin. So majority of the patients, so you know that This subset of patients are undertreated. They have very high LDL cholesterol, so they are high risk for having ASCVD event. So by giving bempedoic acid, if you look at the outcomes, the primary outcome, which was the 4-point MACE, there is a relative risk reduction of 13%. So if you look at the curves, the the primary and the secondary outcomes. So the first figure, which is A, you see the curves are separating after close to 12 months, that is close to 1 year. There is a curve which separates that there is a reduced events in patients receiving bempedoic acid. And if you look at individual components as well, the fatal or non-fatal MI, coronary revascularization, and 3-point MACE, all were showing the similar curves where people who are receiving bempedoic acid, they have reduced events in comparison to placebo. So the effect of trial regimens on CV events, if you look at that, so among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-component MACE, 13% relative risk reduction, 3-component MACE, 15% relative risk reduction, myocardial infarction, 23% relative risk reduction, and need for coronary revascularization, 19% relative risk reduction. So we know that there is a plaque stabilization, there is reduced atherosclerosis, and reduced ASCVD events. So HSC reactive protein, which is the inflammatory marker, we all know that atherosclerosis is inflammation, and whenever there is an inflammation, the levels of HSC reactive protein levels are high. Statins, they are considered to be anti-inflammatory, and they reduce HSC reactive protein levels. Does bempedoic acid also reduce inflammation? So it was found to be reducing the HSC reactive protein levels. So if you look at LDL cholesterol levels, there is a 21% reduction in LDL cholesterol levels. So definitely bempedoic acid levels lower. It is not as good as high intensity statin, where you expect 50% reduction, but is as good as the low to moderate intensity statin to close to 21% reduction in LDL cholesterol level. Importantly, there is also a reduction in inflammation as demonstrated by drop in HSC reactive protein levels close to 22%. So it is acting as an anti-inflammatory and lipid lowering therapy. Now the concern of whenever we add a new molecule, we want to be sure that whether it is safe, does it have any serious adverse events. So serious adverse events were none, which is as equal to placebo. And the most important thing, myalgia, which is not there. So most of the myalgias reported are probably functional. They does not have any significant issue, because we all know that bempedoic acid has zero effect on skeletal muscles. The most important thing being gout, as I mentioned, there is a significant rise in uric acid level, and a small proportion of patients, they do end up having a gout. So we need to be mindful of increase in serum uric acid levels. So those patients who are prescribed bempedoic acid, their uric acid levels needs to be monitored. So the conclusion of the CLEAR outcome study is bempedoic acid becomes the first ACL inhibitor and the first oral, a non-statin, to demonstrate a statistically significant reduction on MACE events in patients who are at high risk with a documented statin intolerance and who are having an elevated LDL cholesterol levels. So it is an oral non-statin therapy which reduces CV events. So the conclusion of today's talk and about the molecule is bempedoic acid is an effective alternative for patients who are intolerant to statins. Statins, it's not a replacement to statin. We do need to prescribe patients on statin, and we need to target high intensity statins, and then we need to focus on the lipid goals. But in those who are not able to tolerate or on whom statins are contraindicated, please do consider bempedoic acid. It is well tolerated for both primary and secondary prevention, and it reduces LDL cholesterol levels and reduction of events, and it also reduces HSCRP levels. So it also act as an inflammatory agent. So both the primary and secondary endpoints were met. So it improves it reduces the MACE events, and it is an effective approach where because it is reducing MACE events. It is effective in reducing the events. So it is proved to be effective in those patients who are not able to tolerate statins. So with this, I will end up my talk. So the key point is there is a significant risk of ASCVD. Identify the patient, stratify their risk, do consider statins, and please encourage statin. Most of the intolerance is subjective. So if we talk to the patients, they will be okay taking the statins. And in those who really have statin intolerance, then we can consider bempedoic acid, which do help improving their outcomes. So I will end my talk. I will be happy to take any questions if there are any. Over to moderators.
Thank you so much, sir. It was such a wonderful, to the point and lucid presentation. There are few questions on my screen I would like to ask. Sir, there's one question is, when exactly you want to initiate bempedoic acid?
So for a patient, I would first risk stratify them, and I would try to define what should be the LDL goal for that patient. And if the patient's once the patient's goals are met or not is being checked, I initiate the patient on a high intensity statin depending on the risk of the patient. So if the patient is at high risk or very high risk, I do initiate the patient on an high intensity statin. I check for their lipid levels 3 months after initiating. Like if a patient who has a recent acute coronary syndrome, you have a baseline LDL cholesterol level, I initiate or discharge the patient on a high intensity statin. I check their LDL cholesterol levels after 3 months to see whether they are on a declining trend. If there is on a declining trend, I do continue the high intensity statin and recheck at 6 months, which is a time for me to make a change. So if at 6 months they do reach my LDL target goals, I continue the high intensity statin for them and I keep monitoring it once in 6 months to 1 year. At 6 months, if they did drop LDL cholesterol levels and if they haven't reached the LDL target goals, this is the time where I have to make an add-on therapy, and which is when I decide on adding bempedoic acid to these patients, equally considering whether I may have to add simultaneous STMIP for them. I tend to go slow. I do not want to mix all of them. I do start with bempedoic acid, although either of the molecules can be taken, but my preference is to use bempedoic acid. So, and then I again reassess their cholesterol levels after 3 months and see for the response. And if they do not reach the LDL targets, then I add the third drug. And if they do not, then again the discussion of the inclusion of PCSK9 inhibitors come. With this thing, what I'm doing, I should say about 60 to 70% of patients were able to reach the LDL target goals with the high intensity. And I did initiate bempedoic acid to maybe about 10-20% of my patients whom I need to follow it up. So currently, I don't have my own experience on how these patients are faring on a long term. Equally, I'm interested and enthusiastic to know how bempedoic acid is able to reach the LDL target for my patients.
Thank you so much, sir, guiding with your in-clinic expertise. The next question is, what is the ideal reduction of LDL cholesterol? Because lower is the better, what you said. So, and any neurological complications occur because we go lower than 30.
Right. So I definitely understand the concern that you have, that how low can we go, and there are a few anecdotal case reports where there is an increased incidence of dementia, there is an increased incidence of strokes, demyelination occurring because of lowering the LDL cholesterol levels. But as of now, there is no substantial evidence to say that lowering the LDL cholesterol levels is actually causing dementia and stroke. These incidences seems to be more of anecdotal. We do not have a clear evidence conclusively today to say that lowering LDL cholesterol levels do produce these adverse side effects. On the other hand, when we look at the data of LDL cholesterol and the incidence of ASCVD events, we do have very strong evidence to say a direct correlation. There are a few instances where we see that patients who have LDL cholesterol levels of 70 are having an ASCVD event, which is kind of paradoxical. We do not expect them to have, which is what it indicates that these patients, even though their LDL cholesterol levels are 70, they are still at high risk. So for them, there is a 50% reduction from that point. So for that patient who had an ASCVD event with an LDL of 70, I have to drop his LDL cholesterol to 50%. So for him, the target will be 35 of LDL or maybe even lower. So that is how we need to see and we need to individualize. So if the patients have a high LDL, maybe you can drop it to the set guidelines of less than 55. But the index case, which I mentioned for a person, a young 50 male who is probably a smoker and has hypertension with an LDL of 70, and if he has an ASCVD event, I would target his LDL goal of 35, a 50% reduction, and I would try to hit him hard because I do not want him to have an ASCVD event for the rest of the life. So I would go aggressive by giving him high intensity statin, and if he's not tolerating or not achieving the LDL goal, I would not hesitate adding bempedoic acid for him.
So there's an interesting point that when baby is born, the LDL cholesterol of the baby is around 30 milligram per deciliter. And once we are talking about neurological complication, of course, newborn baby is not having any kind of complications at that point of time. That's nice to say. When exactly you want to that was covered. The next question is about when in hyperuricemia, what should one do when patient is in hyperuricemia with bempedoic acid?
Right. So there is no clear-cut guidelines on managing hyperuricemia. Most of the times, uric acid levels is also considered to be one of the risk marker for inflammation. And first problem will be is how do we assess uric acid levels in patients who are having or using bempedoic acid levels. So you cannot use uric acid as a marker for inflammation because it is elevated because of bempedoic acid. The second question is about how do we manage this hyperuricemia? Asymptomatic hyperuricemia can be managed without any need for intervention. You just observe, and unless uric acid levels are significantly high, maybe going more than 10, and equally causing any symptoms in the form of any gout, then you do manage with the form of your uricosuric drugs or those drugs targeting on reducing uric acid levels. And role of or managing gout will be the same thing. There is no specific modification. We may have to make a decision whether we should stop this molecule. So it is the so-called risk versus benefit that we need to make a decision. So the risk of ASCVD event versus the risk of having a hyperuricemia and subsequent issues. Most of the time, the uric acid levels are elevated, but many of the patients are asymptomatic, so we can reassure them and you can manage them just like that. But for those patients who are symptomatic, probably managing it like a similar terms by using either allopurinol or febuxostat will do the job, versus if the recurrent events are there, then probably you may have to make a decision of stopping. But that incidence is very, very minimal. Majority of the patients are asymptomatic. You just need to be mindful that uric acid levels can get elevated. Reassure the patient, because patients currently, they do read the reports and they do try to interpret and may panic. So we just need to reassure them. And I think they will be doing okay. It should not cause much of a concern.
Next question is about, can it be used in ACS patient? Bempedoic acid can be used in bempedoic acid for how long? And what is the mortality benefit?
So irrespective of the subset, be it acute coronary syndrome, stable ischemic heart disease, stroke, or any ASCVD event for that matter, bempedoic acid can be used. The goals depends on the risk of the patient. You have these risk scores the ACC risk score or the European score risk or the current score. So you define under which risk category does the patient belong. And based on the risk category, you define the LDL cholesterol goals. How much you can do to reach that goal is the question. So if the patient is able to achieve the LDL cholesterol goals with statin alone, then you do not need bempedoic acid. If you are not able to give statin, or if you are not able to give high doses of statins because of any reason, then you consider bempedoic acid as an add-on therapy. And in those who is not able to take statin alone, we do need to reduce based on the clear outcomes. So for them, bempedoic acid is the only rescue, and you give it. And because these are lifestyle diseases and the risk is there for rest of the life, you need to give these molecules for the rest of the life, or you make a decision on risk stratifying these patients. As they age, probably the risk comes down. So you may consider to de-escalate the therapy. But most of the time, because these are lifestyle diseases, the duration of statins is for the rest of the life, or the bempedoic acid for that matter is for a long duration and mostly for the rest of the life.
Thank you, sir. That was the last question from my side on the screen. Before we conclude, any final concluding remarks you would like to give for the audience?
Yeah, so as I told in my talk, I'll probably re-emphasize the same statement. Understanding each and every patient is different. We need to understand what we are dealing with, whether it is a primary prevention or secondary prevention. The goals are different. The goals of primary prevention and goals of secondary prevention are different. The moment we give high intensity statin, our job is not done. We need to follow it up by repeating their lipid profiles and try to be as aggressive as possible to lower the LDL cholesterol level to reach the goal. There is enough data to suggest that there is a large unmet need. Almost 30% of patients, they do not reach LDL cholesterol goals, which reflects as an event. And up until now, we were not having anything. So the job was easy. You can only give statin and you can relax. But thankfully, we are in an era where the armamentarium is more. So these are these wonderful molecules which are not only effective, but they are also safe and they're also economical. So you can use this molecule, reduce the risk of ASCVD event, and that is what we need to do. So take responsibility of educating the patients about the importance of reducing LDL and reducing their ASCVD risk. And so that is the responsibility that we need to take.
Wow, well, then it was a very indeed a pleasure having you on this Clear Talk and clearing all our doubts on bempedoic acid. Your in-clinic expertise and experience will definitely help all the healthcare practitioners across who are watching this Clear Talk online. And I would like to really thank you, sir, for your wonderful insights and the discussions what we had during question answers. I also would like to appreciate our delegates, all the delegates, all 46 delegates who have joined for giving you valuable time on this platform. And once again, would like to emphasize that as a Zydus, we would like to have that unite against dyslipidemia. And this is one more armamentarium we have brought in, that is Bemdac we have brought in for your patients who are having uncontrolled LDL cholesterol, and let us pass on the benefits of Bemdac to more number of patients wherever it is being recommended by doctor today. So without wasting much of your time, thank you very much, all of you. Thank you, sir, especially for being with us on this evening. Thank you, Praneeth sir. Thanks a lot.